We are going forward with gastroenterology, esophageal disorders. Malarious tear. Malarious tear presents with upper gastrointestinal bleeding after prolonged or severe vomiting or retching. Repeated retching is followed by hematemesis of bright red blood or by black stool. Malarious does not present with dysphagia. There is no specific therapy and it will resolve spontaneously. Severe cases with persistent bleeding are managed with an injection of epinephrine to stop bleeding or the use of electrocautery. Borrhaave syndrome is full penetration of the esophagus. Malarious tear is non-penetrating. It is limited only to the mucosa. Cannabinoid hyperemesis syndrome. The question will describe a patient with recurrent episodes of nausea, vomiting, and crampy abdominal pain. Besides the history of marijuana or cannabinoid use, look for improvement in symptoms with a hot shower or bath. Treat with antiemetics such as endonsulfan or benzodiazepines such as lorazepam. Patient better with hot shower. Cannabinoid is the answer. Epigastric pain. The epigastric area is the part of the abdominal surface just beneath the xiphoid process and in between the two sets of ribs. It is above the umbilicus. Pain in the epigastric areas is common, occurring in as much as 25% of the population at some point in their lives. Tenderness, which is increased pain on palpation or pressure in the epigastric area, is far less common. The presence of pain, which is a complaint or sensation that is stated by the patient. It is not the same thing as tenderness. Tenderness is a physical finding on examination. Patients hospitalized with epigastric pain are far more likely to have ulcers, biliary disease, pancreatic disease, cancer, and gastritis with bleeding. Here we have a question. A 44-year-old woman comes to see you because of pain in her epigastric area for the last several months. She denies nausea, vomiting, weight loss, or blood in her stool. On physical examination, you find no abnormalities. What is the most likely diagnosis? Duodenal ulcer disease, gastric ulcer disease, gastritis, pancreatitis, non-ulcer dyspepsia, or pancreatic cancer. Only endoscopy can truly give a precise diagnosis. Here the answer is E, non-ulcer dyspepsia. This is very often a hard question for the average medical student. This is because of the selection bias of which cases you as a student see admitted to the hospital. Non-ulcer dyspepsia is by far the most common cause of epigastric pain and at a minimum accounts for 50% to 90% of all cases of epigastric pain. This is particularly true in patients under the age of 50. In the hospital, you will see far more patients with ulcer disease, pancreatic disorders, or cancer because those are the ones who are admitted. Non ulcer dyspepsia is virtually never a reason to be admitted to hospital. Here we have an important table about how to answer the what is the most likely diagnosis questions about epigastric pain. If if this is in history, the most likely diagnosis is if pain worse with food, it's most likely gastric ulcer. If pain better with food, it's most likely duodenal ulcer. If there is weight loss, cancer or gastric ulcer. If there is tenderness, pancreatitis is most likely diagnosis. If bad taste, cough, hoarseness of voice, it is most likely gastroesophageal reflux. A patient is diabetic and complaint of bloating, most likely is gastroparesis. If nothing, then most likely is non-ulcer dyspepsia. Means epigastric pain is there, but the above mentioned complaints or findings are not there, then it's non-ulcer dyspepsia. Diagnostic test. Endoscopy is the only way to truly understand the etiology of epigastric pain from ulcer disease. Radiologic and barium testing are modest in accuracy at best. You cannot biopsy with radiologic testing. In the esophagus, barium studies may show barium studies may be a good place to start with testing, but in stomach, barium is very poor. Here we have a figure explaining causes of abdominal pain by location. If it is in mid-epigastrium, it can be pancreatitis or aortic dissection or peptic ulcers. If it is in right upper quadrant we have gallbladder, cholecystitis, biliary colic, cholangitis, and or perforated duodenal ulcer. Right lower quadrant we have appendicitis, we have cecum, cecal diverticulitis, and fallopian tubes and ovary are on both sides. So ovarian torsion, ectopic pregnancy. Left upper quadrant, we have spleen. It can be splenic rupture or it can be IBS, splenic flexure syndrome. Left lower quadrant, we have sigmoid colon. It can be sigmoid volvulus, sigmoid diverticulitis. Ovary and fallopian tube are on both sides. So ovarian torsion and ectopic pregnancy can be. Treatment of uh, this non-ulcer dyspepsia. Proton pump inhibitors are always a good place to start in the therapy of epigastric pain. There is no difference in the efficacy of different PPIs. Misoprostol is always a wrong answer. H2 blockers like ranitidine, nizatidine, cimetidine, famotidine are not as effective but will work in about 70% of patients. Liquid antacids have roughly the same efficacy as H2 blockers. Misoprostol, an artificial prostaglandin analog, was developed just before the invention of proton pump inhibitors. Misoprostol was designed to prevent NSAID-induced gastric damage. When proton pump inhibitors arrived, misoprostol became obsolete and a wrong answer on the test. GERD. GERD is the inappropriate relaxation of lower esophageal sphincter, resulting in the acid content of the stomach coming up into the esophagus. Symptoms of GERD are worsened by nicotine, alcohol, caffeine, chocolate, peppermint, late night meals, and obesity. What is the most likely diagnosis question? GERD is the answer when you see epigastric burning pain radiating into the chest. There are no unique physical findings in GERD, it's a symptom complex. The patient also complains of sore throat, bad taste in mouth, hoarseness, or cough. You do not have to have all these extra symptoms present in order to GERD is the most likely diagnosis. It's not necessary. A 42-year-old man comes to the office with several weeks of epigastric pain radiating up under his chest, which becomes worse after lying down flat for an hour. He also has a brackish taste in his mouth and a sore throat. What is the most appropriate next step in the management of this patient? Ranitidine, liquid antacid, lansoprazole, endoscopy, barium swallow, 24-hour pH monitoring. The question is most appropriate next step. The answer is C. Lansoprazole. Lansoprazole is a PPI that should be used to control the symptoms of GERD when the diagnosis is very clear, such as in this case, with epigastric pain going under the sternum, bad taste, and sore throat. Confirmatory testing is not necessary. H2 blockers such as ranitidine are effective in about only 70% of patients, so they are clearly inferior to the PPI. We have a PPI in the option. Endoscopy does not diagnose GERD and is certainly not necessary when the diagnosis is so clear. Barium swallow shows major anatomic abnormalities of the esophagus and is worthless in GERD. Diagnostic tests. GERD is a symptom complex that is most often diagnosed based on patient history. In some patients in whom the diagnosis is not clear, 24-hour pH monitoring is done to confirm the etiology. Endoscopy will show nothing when there is only heartburn. Endoscopy is indicated when there is signs of obstruction such as dysphagia or odynophagia, weight loss, anemia or heme positive stools, more than 5 to 10 years of symptoms to exclude Barrett's esophagus. GERD may show redness, erosion, ulceration, stricture or Barrett's esophagus on endoscopy. Treatment. All patients should lose weight if obese. Avoid alcohol, nicotine, caffeine, chocolate, and peppermint. Avoid eating at night before sleep within 3 hours of bedtime. Elevate head of bed 6 to 8 inches. Mild or intermittent symptom may be treated with liquid antacids or H2 blocker. Persistent symptom or erosive esophagitis, proton pump inhibitor. There is no difference in efficacy between different proton pump inhibitor, whether it be lansoprazole, pantoprazole, omeprazole. Treatment to those not responding to medical therapy. About 5% of GID patients do not respond to medical therapy. These patients may require surgical or anatomic correction to tighten the lower esophageal sphincter, such as Nissen fundoplication, wrapping the stomach around the lower esophageal sphincter. Uh, Endo-inch, using a scope to place a suture around the LES to tighten it. Local heat or radiation of LES, it causes scarring. Barrett's esophagus. Long-standing GERD leads to histological changes in the lower esophagus with columnar metaplasia. Columnar metaplasia usually needs at least 5 to 5 years to develop. There are no unique physical findings developed there. Only endoscopy can determine the presence of Barrett's esophagus. Biopsy is the only way to be certain of the presence of Barrett's esophagus and of dysplasia. This is indispensable because the biopsy drives therapy. Columnar metaplasia with intestinal features has the greatest risk of transforming into esophageal cancer. Each year, about 0.5% of the people with Barrett esophagus progress to esophageal cancer. If we are finding Barrett's alone, management is proton pump inhibitor and a rescope every 2 to 3 years. If we are finding low-grade dysplasia, PPI will be there, but rescope every 6 to 12 months. If there is high-grade dysplasia, ablation with endoscopy, photodynamic therapy, radiofrequency ablation, endoscopic mucosal resection. Next, we will see about gastritis.